Thank you very much, Madam Chairperson. I'm very happy to be here at the 10th MPAI conference, and I consider it a huge honor to be speaking here, and I'd like to thank the organizers of this meeting for having called me here. The topic I've chosen is cervical cancer, and in a country like India, where we contribute to 1/5 of the annual cervical cancer cases, 1/5 of the cervical cancer deaths per year, and where 80% of cervical cancer is in the low and middle income countries, I think this is a topic that is quite germane to all of us. So, the Director General of the WHO had recently tweeted to say, cervical cancer, even though so common in the developing world, is a highly preventable and treatable cancer. In fact, it could be the first cancer ever to be eliminated. Well, that's a tall order. And in keeping with WHO's targets, elimination targets, which are set at 2030, there are 3 measurable global targets to prevent and treat this cancer. By 2030, 90% of girls should be fully vaccinated with the HPV vaccine by as young as 15 years of age. 70% of women should be screened with the high performance test by the age of 35, and again, 10 years later at the age of 45. And 90% of all those identified with cervical disease should receive appropriate treatment. We all know today, of course, I'm a minority here, I'm a virologist in the midst of many eminent pathologists and molecular pathologists, but cervical cancer screening has evolved dramatically in the last 2 decades. Today, HPV testing is recommended as a first-line testing in primary cancer screening. It's a part of co-testing along with cytology. It may be a part of post-treatment follow-up, even after you have treated a woman, say, with radiation, who has invasive cervical cancer. And today, HPV testing takes an important role in the era of expanding immunization, HPV immunization globally, to look at the impact, apart from cytology, the impact of what vaccination is doing to populations, especially in the context of types that are not covered by the vaccine, HPV genotypes that are not covered by the vaccine. So I just want to take you through the natural history of HPV infection. First of all, we all know HPV, human papillomavirus, is perhaps the most common sexually transmitted infection. 80% of women develop this infection easily. And how does this virus get into the cervical epithelium? So on your left is the, don't know whether the pointer is working, I'll use the cursor. On your left is the normal epithelium, and through microabrasions, actually, virus particles following sexual activity with a partner who's already infected, the virus gets into the basal epithelium and sets up a productive infection. That means produces virus particles within the layers of the epithelium here. The virus is episomal, not integrated with the host cell nucleus, and its only job is to keep making more of its own as the cells slowly differentiate, and finally, when it reaches the top layer of the epithelium, with desquamation and also active virus release, fresh virus particles are released into the gentle fluids to probably infect yet another person. So this is what happens most of the time, and this is called productive infection. Occasionally, what happens is over a long period of time, with a number of predisposing factors, the main predisposing factor being persistent infection, then infection with high-risk types, coexisting immunosuppression, particularly HIV co-infection, and also a genetic predisposition for cancer. What happens is what became an episomal viral infection becomes integrated the viral DNA gets integrated into the host cell. There's abundant production of two of the virus's major oncogenes. You might have heard of the E6 and E7 oncogenes produced by the virus. These are early oncogenes, early genes, but it's depicted here in the circularized genome here. These two genes are overexpressed. They do a lot of havoc there. They interfere with tumor suppressor proteins. They can actually interfere with antigen presentation itself to the immune reactive cells. And that's how, over a 10 to 30 year gap, what started as a fairly self-limiting infection, which could even undergo regression, this infection can proceed to invasive cancer. We all know that there is a whole spectrum out there. We start with the normal cervix. As the virus is replicating, there are low-grade intraepithelial lesions, high-grade intraepithelial lesions, both of which can undergo reversal, regress, and become normal again. Most infections clear by 2 years of age. It's more the exception than the rule when they go on to cause invasive cancer. And then if you look at biopsy pictures, the low grade is equivalent to a SIN1, and the high grade squamous epithelial lesions, intraepithelial lesions, are equivalent to a SIN2 and a SIN3. And of course, you have invasive cancer at the far right. So to take you through progression and regression of HPV infection, we have HPV infecting normal normal cervical epithelium. Very often, as I said, that infection gets cleared within 2 years. High-risk HPVs may take little longer, but usually within 2 years. And there is clearance of the infection in this period of time. And under circumstances of persistent infection, there is a risk to progression to higher grades of intraepithelial squamous neoplasia, and you go on to the SIN1 and SIN2. And I want to bring to your attention that even when individuals go up, develop SIN2 and even SIN3 lesions, a good number of them are likely to regress. It's the minority, about 0.8 to 1%, that will go on to invasive cancer. So if you look at SIN2 lesions, which are at the, the junction of whether it would reverse or go to a SIN3 and then invasive cancer, 40 to 58% of SIN2 lesions are likely to regress, and only 22% will go on to form SIN3 lesions. And in younger women, that's even more. 70% of women are likely to regress from a SIN2 lesion. So a SIN2 doesn't necessarily mean a gloom and doom story. It's important to identify those who are truly at risk for progression and those who are likely to regress. So, as I had mentioned, HPV testing has come to stay. It is the assay that's now used for large-scale population-based screening for cervical cancer. And a negative high-risk HPV test has one important use. It has an exquisitely high negative predictive value. However, its positive predictive value, and we heard about that from Dr. Monzin's presentation, the importance of inching that up. Unfortunately, HPV infection leading to SIN2 lesions have a lower positive predictive value, and it's very important to triage women to reduce unnecessary referrals and overtreatment. In our country, overtreatment is you just remove the uterus. Easiest to do. Just go ahead and, we were involved in a study. I won't mention which state because it shouldn't be stigmatizing. We were involved in a community study for cervical cancer, self-collected swabs. And we found many of the middle-aged women were minus their uterus. So it's very easy to just, throw it into the bucket. And the need for molecular markers is definitely required to better discriminate the presence of high-risk HPV in those women who are at a higher risk of actually moving on in the direction of invasive cancer, or those that are not. Just to give you an idea of what the high-risk HPVs are, we are on the top of that row is all the oncogenic or carcinogenic HPVs. Definitely 16, 18 up to 59 are well-established oncogenic HPVs. 66 and 68 sometimes reclassified as probable high risk, but the real meanies here are the oncogenic HPV 16 and 18. Low risk, not of our concern for this particular discussion, but I highlighted 6 and 11 because they are low risk, but they are incriminated in causing genital warts. So one of the first measures to reduce those unnecessary referrals was to introduce an HPV 16 or an HPV 16 or 18 specific assay. And these, as I said, are the genotypes most associated with cancer causation. So when just mere HPV testing has been improved on by looking for HPV 16 or 16 or 18, and some also look for HPV 45. So you may be familiar with these algorithms. Many of the national bodies in different countries have their own algorithms. This actually refers to the algorithm in Australia, where after a primary HPV test, you are actually doing an HPV 16, and if it is positive, you can choose to do a reflex liquid-based cytology, but definitely an HPV 16, 18 positive must be followed up with a colposcopy. But if you have a negative HPV in the woman, as I told you, the negative predictive value is so high, the woman can be recalled with a longer screening interval. If you have other HPVs, definitely reflex LBC will help you to triage as to how soon you want to follow them up, or whether you actually, if you have an ASCUS-H, for instance, ACH, you definitely want to follow it up with colposcopy like these individuals, and that helps you figure out who are the women you want to give more focus to. There are other technologies that are available to try and help you figure out whether this CIN2 lesion is more sinister than you'd like it to be. And definitely the presence of mRNA of E6 and E7 genes is a sentinel marker that there is active replication of the virus in the cervical epithelium, and it is actively producing these oncogenes. It's associated with persistent infection. It's associated with disease progression. It definitely is a better cancer predictor than just presence of DNA, and the specificity of the assay also is much more. So if you look at the spectrum, normal through different stages of cervical intraepithelial neoplasia and invasive cancer, you'll find that the amount of E6, E7 mRNA is increasing with progression of disease. DNA actually, the amount of DNA, if you actually quantify, may be less in very far advanced cervical disease. So when the virus gets into the cell, the viral DNA initially I mentioned is episomal, but with persistent infection, this virus can actually, viral DNA can get integrated into host DNA, and simultaneously there's an overexpression of E6 and E7. Viral oncogenes are clearly detectable in such tissue, and therefore another marker that will help you decide, in addition to HPV 16-18, is the E6, E7 mRNA. There are different platforms. Aptima is a transcription-mediated amplification assay, which uses the concerted efforts of reverse transcriptase, RNase H, and RNA polymerase. This is an isothermal reaction. It can detect mRNA of high-risk types. There are Aptima assays that will look only for the top 3 oncogenic HPV types. It's a well-established assay, FDA approved. And the good thing is it's an isothermal reaction. There are other assays also that look for mRNA of E6, E7. There's a PRETEC PRUFA assay, again, a NASBA, nucleic acid sequence-based amplification assay. It is, again, very good at picking up RNA. It can multiply, it can detect RNA amplifiable over 1 billion-fold in a very short period of time. Oncogenic HPV is a quantitative assay using flow cytometer and in situ hybridization. And finally, you can even have an in-house real-time quantification assay to look at the amount of mRNA in different stages of cervical neoplasia. The Oncogenic, which I alluded to, where they use flow cytometry and in situ, basically the cells that are exfoliated from the cervix are fixed, made more permeable, and then you use a DNA probe that is conjugated to a fluorochrome. And then when you allow that binding to happen and wash those cells, by flow cytometry, you can pick up the number of cells that actually have got the E6, E7 mRNA within them. In our own center, way back in 2009, we published that we looked at those with SIN3, actually, mostly SIN3 in this category, and different stages of invasive cancer, 1, 2, 3, and 4, which we still do see in our country. And we found that when we quantified mRNA, you can see that with advancing disease, mRNA, amount of virus loads of mRNA was much higher. In fact, it had no correlation with DNA virus loads, but mRNA virus loads increased with the stage of the disease. We also know that epigenetic processes do have a role to play in cervical carcinogenesis. We spoke about early infection, which resolves within 2 years, and that early infection where the virus is episomal, just producing more of its own, is called productive viral infection. And when it goes on to SIN2, SIN3, where E6, E7 is beginning to be expressed, these are called transforming infections of the cervical epithelium. And that can also regress, but also has a risk of going on to cancer. Early stages definitely will regress. Advanced stages are likely to go towards the direction of cancer. And you will see that DNA hypermethylation increases the more advanced the lesions are. We know epigenetics are heritable changes in gene expression without actually alteration of the viral or host DNA. This epigenetic regulation may involve DNA methylation, histone modification, or even new species of miRNA expression. It may be triggered by environmental factors, including viral infections, immunosuppression, and many of these changes occur well before they can be perceived by histopathology, and therefore serve as good biomarkers for early diagnosis and risk assessment. One of the promising methods is looking specifically for DNA methylation. Those of you are looking at cervical cancer, this is an area that is gaining a lot of attention. Faster methylation is linked to higher risk of progression, and there are a number of assays available today to assess DNA methylation in the cervical epithelium. There are a number of commercial assays today, and I've highlighted them in brackets here for you, that would look at different genes, mainly host genes, some viral genes, which would suggest that the methyl group has been transferred to cytosine. And what is the significance of this? It often leads to gene silencing, and you can see here there are a plethora of different commercial assays to assess the DNA hypermethylation in different tissues, including in cervical cancers. There are also protein biomarkers that could be used, and they serve as very important tools because some of them are linked to increased cellular proliferation and loss of cell cycle control. And usually we use in situ hybridization, either in cytological specimens or in biopsies, to assess it. And one of the best known, which all of you are familiar with, is the expression and accumulation of the P16 protein in biopsy specimens or even cytological specimens. And that today is paired with another marker, which is associated with cellular proliferation, namely the Ki67. Today, co-expression of P16 and this Ki67 is found to increase in the more the transforming the lesion is, and usually this is done with a dual stain immunohistochemistry. This is actually studies from our center, which was published last year, where this dual staining was used. We found it had a higher specificity and a better positive predictive value than merely HPV DNA. And what you're seeing in the top left is the positive control, negative control. And you can see that in an HSIL, it is quite prominent, whereas in lower grades of intraepithelial neoplasia, it is not so stark. There are other protein biomarkers, such as another early gene of HPV known as E4. Usually E4 expression is enhanced in the early stages of the productive stage of virus replication in the cervical epithelium. But as the lesion is progressing, getting more transformed, E4 expression comes down, and that also can be used as a prognostic marker. There are many other new protein biomarkers looking for CD103, particularly in biopsy tissue. This is correlated with enhanced CD8 infiltration. You know, CD8 cells are very important for trying to destroy tumor cells. Also, angiopoietin 1-2 ratios have served as diagnostic or prognostic markers, and a whole slew of other protein markers that could help to prognosticate the stage of the lesion and the risk of progression. I've just enumerated them here. And just as you had heard in the first lecture by Dr. Block, chromosomal damage is also seen in cervical intraepithelial neoplasia. A variety of changes happen in the epithelium and is linked with progression of disease, and this can be easily studied using FISH. I've not gone into different aberrations, but just to say that that is an area that is also being tapped on to triage individuals, though it's not something that's easily done. So to summarize, triaging positive HPV DNA individuals, especially at stage SIN2, requires further testing. HPV 16 or HPV 16-18 testing would be useful. mRNA detection of E6, E7 increases the specificity. Methylation markers, mRNA detection, also good for prognostication. Many of you are familiar with the P16, Ki67 dual staining using IHC. Reduced E4, early gene 4 detection in tissues also linked with progression. And as I had mentioned, chromosomal damage does occur with progression of cervical intraepithelial neoplasia. A combined approach certainly would give us better diagnostic and prognostic markers. But where are we in terms of the future? Certainly, as was mentioned by Dr. Monson too, more extensive and long-term studies are needed to assess their true application when we take it to the population. We need to make sure that while we're trying to increase that positive predictive value, we should not have false negatives. Such triaging assays should be adapted to technologies that do not require expensive equipment or very skilled personnel, because that would increase the cost of testing. We need to, especially when it comes to protein biomarkers, look for simple and robust systems like lateral flow assay or integrated microfluidic systems, which may be easier to do as point of care and may be cheaper and will not require expensive instrumentation or very well-trained personnel. Affordability, and that is my punchline finally, is the cornerstone to any program, particularly in the low and middle income countries, because we have quite an array of assays we can use. But is it affordable? Is it doable? Is it attainable and achievable? in low resource settings is the key. And with that, thank you for your patient listening.